diabetes, peripheral arterial disease in diabetic patients, they were 78%, while the diabetics who is not having peripheral arterial disease is 47%. So you can imagine how big the numbers are. This study estimated the prevalence of peripheral arterial disease in the Saudi Arabia by 11.7%. They calculated a round figure that 400,000 of the Saudi population classified as peripheral arterial disease. This is again 2007. Things are increasing. Different pattern from the non-diabetics. They affect younger patients, has no sex difference. We know that the non-diabetics, the males are more than females in the atherosclerosis, but in the diabetics, this sex difference was not found. They are rapidly progressive, increased calcification, and more distal lesions. So this is the characteristic of arterial lesion in diabetics. So what are the major problems in diabetic foot? The major problems, we have three major problems in diabetic foot. Number one, ischemia, whether microangiopathy or macroangiopathy, peripheral neuropathy, this is the second point, and infection is the third point. Foot ulceration, sepsis, amputation are known to every diabetic patient and feared by almost every person who is having diabetes. Every diabetic patient, his major fear is amputation. He's very afraid that in certain period of his life he may have amputation. And the sarcastic thing that these are the only potential most preventable complications among all complications of diabetes. Meaning what? Meaning that if this patient is going to have retinopathy, for example, in his eye, he will have retinopathy. Whatever you do, he will have retinopathy. If this patient is going to have nephropathy, kidney problems, ending by renal failure, he will have this, whatever you do. But the only complication that you can prevent really is the amputation. So you can imagine how big the problem, and it is the only preventable problem in the diabetes. This looks a little bit complicated, but actually it's very simple. This is how the foot ulceration occurs in diabetes. If we know that diabetes makes only three things: this limited joint mobility, and this green one is the diabetic neuropathy, and this blue one is the circulatory or the vascular problem, whether microvascular or macrovascular. So this limited joint mobility with the motor damage makes some change in the pressure points of the foot and ends by callus formation and ulceration. Okay, this definitely will be increased if the patient is having vascular problem. This will cause ulceration. Of course, it will be much exaggerated if infection is also there. So the message here is prophylaxis, number two, prophylaxis, and number three, prophylaxis. Prophylaxis is very, very important in diabetic foot. It can be very simple, but the treatment could be very difficult. So, how to save a limb in 3 minutes? This is a joke, this is not a joke, but the diabetologist, the family medicine doctors, the general practitioners have this chance. He can save a limb in 3 minutes. What to do in these 3 minutes? First, take 1 minute to feel the pedal pulse. If the doctor is having the habit of feeling the pedal pulse, this is an excellent tool. It will not take more than 1 minute to feel both right and left pulses. So this is 1 minute, and take another 2 minutes to tell your patient what to do and what not to do. This is very important, and don't think that your patient is intelligent enough to know these things. Definitely he knows. No, definitely he doesn't know, and definitely it's our duty to educate the patients. All of us should acquire the habit of feeling peripheral pulses, as we said, and if we did not feel whether the dorsalis pedis or posterior tibial or at least one of them, this is the time to consult vascular surgeon. So what to tell our patient, what to do? Number one, clean the feet regularly, and don't take it as granted that definitely the patient is cleaning his foot. Definitely the patient is not cleaning his foot regularly. So to clean the foot regularly is very important. Number two, to dry the foot always. Most of us having the habit of making wudu, for example, and dry everything but leaving the foot to be dry by itself. This is not acceptable in diabetic patients. So clean the foot regularly, dry the foot always, and avoid dryness of the skin using cream, any kind of cream, not necessarily medical cream, any kind of cream at home, or even olive oil, whatever the patient likes to use, is allowed to use. Next, avoid fungal infection, and you have to teach the patient what is fungal infection and where to look between the toes. This is a diabetic foot patient. As you see, there is no wound yet, but the skin is very thin, very papery, very easily to be injured. So this foot should be taken care of. And these are the weapons, and I call them weapons because really there are weapons to fight the amputation. This is soap, and this is the stone used to remove the dry skin from the heel, and these are some cream. It's very simple: soap, stone, and cream. Put a daily protocol for your patient. Don't leave the patient to be doing whatever he likes whenever he likes, but at least give him a protocol. Tell your patient that you should have cleaning your foot every night, drying your foot, putting cream before you go to the bed. If you put the patient on a protocol like do 1, 2, 3, he will follow this. So putting a daily protocol for our patient is very important. Again, what to do else? Check the feet daily, and don't expect that this is done by nature. It is not done by nature. The patient will not have good sensation in the foot, so he may have some wound, some pin, some nail, anything enter the foot while not aware of this. And the best is to be done by a relative or anybody at home. Okay? So don't forget that your diabetic patient is old age, having some back problems, some osteoarthritis. He cannot check his foot. Plus, he may have some retinopathy also and cannot see well. So it is better to be done by the son, daughter, wife, whatever available at home. We should choose the appropriate shoes. What do we mean by appropriate shoes? Appropriate shoes should be soft, should be covering the whole foot, should be in a good quality, should having some criteria for the diabetic patients. And we have a lot of these shoes in our countries. Next point, choose the appropriate socks. The socks should be cotton, not artificial, not synthetic. These cotton socks will absorb the sweat. Should not be tight, otherwise it may cause some problems for the patient. Okay. Next point, trim the nails flat and carefully. This is very, very important. It's very important that the patient having his nails cut flat, not much, especially from the sides, and don't forget that the patient is not having good sensation in the foot, so he may cut the nails and still cutting the skin without having any pain. So it is better to be done by a relative again. Last point, check the shoes from inside and outside. It's very important point, which is definitely not done by all of the patients, or at least most of the patients, that he having his shoes in front of his eyes and look, or even some relative, he can hold the shoes and just put his hand like this, just make sure that nothing is inside. And I have patients who had some nail inside the shoes for days, and they are wearing these shoes without having noticed even this. So these are an example for the shoes. These are also an example for the shoes. These are covered shoes, as you see, soft. This also can be used, and this also can be used. These are the nails. They should be cut flat like this. Should not be left like that at all. As you see, this cutting here is making some inflammation. And if this patient is having arterial problem, he may end up by a major problem. This is the socks. As we said, must be comfortable, cotton, and better to be high below the knee. Just teach your patient or the son or the relatives how to examine the foot of his father or mother or whatever the patient is. So how to examine the foot, where to look. And this is the fungal infection. We should teach our patients and our relatives where to look for this fungal infection and how to be treated. And of course, drying always is a prophylaxis against the fungal infection. This is a mirror with a long shank. If the patient is staying alone at home, or he's having no relative to look for his foot every day, so he can use this mirror to see there are blind areas in the foot. Many of us does not see the sole of the foot. It needs some elasticity of the legs to switch the foot and look for the sole. So this mirror can do the job. Then feel. We used to look, but we have to feel the foot, because sometimes there is hard areas, there is callosities, some wound, something we did not see yet, but you can feel it. So to look is not enough, but we have to feel also. These are the pressure points of the foot during walking, and these are the normal pressure points. But with the diabetic patient, this pressure points is changing. Sometimes, as you see, this is callosity due to a pressure point. This could have very big problem behind it. These are ulcers that the patient is not aware of it. He has no pain in the ulcer, and he cannot see it because it's in a blind area in the sole. He cannot twist the foot to look, and he's not feeling any pain, so he can walk with months for this with this ulcer without even knowing that he's having ulcer. This again ulcer that is not seen by the patient. This is the monofilament we use to detect if this patient is having peripheral neuropathy or not. The sensation will be definitely less in some areas of the foot. Okay, now we took 1 minute to feel the pulse, 1 minute to tell the patient what to do, and the third minute what not to do. These are very important points you should tell our patients not to do. So the first one, most of the people, I'll not say most of the patients, most of the people are having the habit of using the shoes till it is completely old, then throw it and buy a new one. This is not allowed for the diabetic foot patient or the diabetic patient in general, because every shoes, when it is coming old, it having definite some pressure points. So day by day and week by week, these pressure points can have an ulcer or beginning of an ulcer in the diabetic foot. So what should we advise the patient to do? The best is to having two shoes at the same time, and they can use them alternating, whether this today and this tomorrow, or this in the morning and this is at night, but whatever he likes, just alternating will alternate the pressure points, which is this shoes like that and this shoes like that, so it is better to alternate them. And also, he's not allowed to use tight or uncomfortable shoes to avoid callosity. These uncomfortable shoes or the tight shoes will cause callosities that may end with a problem. These are some machines now used in the centers of the diabetic foot to check where are the pressure points of each foot, because the diabetic patient is not having a normal position of the foot and normal position of the pressure points. Usually he may change the pressure points and he may have this foot having different pressure points than the other foot. So this is very important. If we having a problem in the foot of the patient, we should send him for something like this to make the regular or the right shoes for him. Again, what not to do else? Some people are having the habit of wearing the shoes and the socks, and after going home, he removes the socks, scramble it and put it inside the shoes and to use it again when he's going out. The diabetic patient is not allowed to do this. Don't forget that the socks is wet from the sweat of the foot, and when you just make like that and put it inside the shoes, it keep wet and invite infection when the patient use again. Okay, he's not allowed also to use old stitched socks. This old socks, when having a tear or some tear in the socks, is not allowed to sew it and use it again, because this tear, which is stitched or sewed, will make a pressure point in the foot when he's using the shoes. Okay, he is not allowed to step in hot water bath without feeling the water with his hands first. Don't forget that he's not having sensation in the foot, and he may have burn in the foot from the water because he will not have any pain. Okay, and just to show you how this could happen, this is a patient who stepped in a hot water bath, and the result, as you see, complete burn of the foot. So it can be a beginning of a very big problem. Again, what not to do else? Advise your patient not to remove the callosities by himself. Otherwise, he may cause an ulcer which he is not aware of. He's not allowed to walk barefooted to avoid unnoticed injuries. Okay? He can have injury and he's not fully aware of it. Again, don't ignore any minor injury in the feet. Sometimes he's having minor wound in the foot and he's saying that it will heal, but for a diabetic patient, he's not allowed to do this. Even if it is minor injury, he should go to the doctor. This is what I call the blessing of pain. Blessing, it's a God blessing of pain. This pain is very good, and it's a warning from Allah subhanahu wa ta'ala against any injury. And I'm sure that we all prefer to be this person than to be this person. This person is not having a sensation at all in the foot, and you can see the nail is going very smoothly in the foot without even giving him any pain. This is another patient who came to the clinic with this. He was not aware that he's having pain in his foot. Don't forget that he's having problem before because he removed the 4th and 5th toes. Okay, this is the pain removed, and the patient is not completely aware from any problem of this. So this is what I call the blessing of pain. This is a blessing. Nobody will know it unless the one who lose it. A small injury while trimming the nails can end by major amputation. This is the very common scenario, and anybody who's working in diabetic foot clinic will definitely meet this scenario many times in his life, that the patient is having a small injury while trimming the nails, which made some infection, ended by some gangrene, and was not treated in a good way, and the infection spread and has to be amputated. So this is a very bad scenario. Small injury can end by major amputation. Between this injury and the amputation, 3 things happened, or 3 factors that led that this small injury will end by amputation. Number 1, uneducated or negligent patient. If the patient is negligent, nothing I can do for him, but is uneducated, this is my duty, this is your duty, this is every doctor's duty. Our duty is not only to treat the patients, but also to educate them. So, uneducated patient, this is factor number 1. Factor number 2 is busy doctor who's not having this 3 minutes for his patient. He's not having time to sit with the patient and give him the advice what to do and what not to do. And the third factor that lead to amputation is a lot of what we call scratch operations, that this patient is having a big infection, but a doctor is making a very small incision because he's afraid to do very large incision, or under the false impression that diabetic wounds does not heal easily. So as much as possible, we should be aggressive with the diabetic foot patients. If prophylaxis is better than treatment, if we took this sentence and applied to medicine, if it is valid only for one thing in medicine, it is valid for diabetic foot infection. Because the prophylaxis could be very easy, while the management could be very difficult. How to manage? If there is infection, adequate drainage and aggressive debridement. And I am sure that I stress again on aggressive debridement. If there is ischemia, we should do revascularization. Okay? Never debridement before revascularization, except in one exception only, if there is pus drainage. Pus should be drained immediately. But if there is infection that needs debridement, and this should follow the revascularization. Prophylaxis, as we said, is very easy, while management sometimes could be very difficult. This is an angiogram for a patient who had ischemia and, as we said, needed a bypass from the saphenous vein down here to the dorsalis pedis. So this is saphenous vein coming from the femoral artery up to the dorsalis pedis. This is the saphenous vein making the bypass, and this is the anastomotic line between the saphenous vein and the dorsalis pedis. And as you see, even the posterior tibial artery started to fill from the arch of the foot. But this ended like that, which is an excellent result in a diabetic foot patient. Again, this is another patient who's having diabetic foot infection. This is a CT angiography showing the aorta here and the two femorals here. There is no rest of the aorta, there is no common iliac, there is no external iliac even. Okay, so the ideal for this patient is aortobifemoral bypass, but because this patient had recent MI and was refused by the anesthesia for aortobifemoral, so we had to make axillobifemoral, just taking from the axillary artery. This is an artificial graft, as you see, and coming here, this is to this femoral and to this femoral, and again another bypass from this femoral to the popliteal down. You can see these are the whole graft coming from the axillary to femoral here and the femoral there, and another bypass coming from this graft to the popliteal down here. So you see how much graft we needed to revascularize the foot. We coming from the axillary artery to the femoral artery to the popliteal artery. You see, this is a huge work to do. But this patient ended like that. You know, we just removed the second, third toe, and as you see, the vascularity is okay. Now we have good red granulation tissue. So remember that the situation inside the foot in many wounds is usually much worse than it looks outside. Sometimes you see a patient with a small infection or a small gangrenous patch that looks very small, but actually it is the tip of iceberg. You can see when you start the debridement that a lot of infection and a lot of dead tissue is below. And the more aggressive the treatment will be, the more chance your patient will have for saving his limb. And just to give an example what I mean by aggressive debridement, this is a foot of a patient having gangrene in the little toe with some blackish discoloration here. The fourth, third and second toe looks from outside okay, but once we started to remove this, we found that the infection is spreading and we had to remove this and this and this. So it came like that. Okay, so we had to remove the 4 toes and remove this incision in the leg. It's not in the foot. The infection was reaching there. Okay. But somebody will ask how this will heal. And the answer is very simple. If it is clean and having good vascularity, it will heal. This is the same patient. This is 6 weeks later, and this is 8 weeks later, 2 months. The patient started to heal. And this is again 10 weeks, and this is 12 weeks. 12 weeks, 3 months, it's about to heal completely, and this is the final result of this patient. 4 months later, complete healing, and the patient is walking normally on his foot, having the heel having the big toe and having the rest of the sole, he is walking normal. This, of course, much better than this. Many factors are needed to save the patient's foot, but one of the most important factor of saving this foot